on our website. So we can get started. So good morning, attendees, speakers, and faculty. For those of you who were with us yesterday, hello again. And for those of you who are just joining us, welcome. We had a great first day of the Northeastern University Global Health Initiative's third annual conference, COVID-19 and Racial Equity, or C.A.R.E 2021. And we received great feedback from attendees and panelists, and we're super excited to get started with day two. And before we begin, I would like to reiterate our sincerest appreciation to all of you who helped make this event possible, specifically to the Office of Undergraduate Research and Fellowships, the Institute for Health Equity and Social Justice, and our Faculty Advisory Council. Without you, none of this would have been possible. I'd also like to offer a few words before we begin day two. We understand that in all facets of global health, from mounting this global pandemic responses to commercializing and generalizing healthcare information, work is far from finished. And in fact, it would not be a stretch to call out how dramatically unprepared we are for the future. So we are, and at the end of the day, we are working to build a better future for everyone, which is what we hope to achieve through this conference. And we're excited to kick off day two that will focus on racial and health inequities. We have a great lineup of speakers for you today, and unfortunately our keynote, Dr. Cassandra Pierre, had to cancel, but we are again excited to kick off with this panel that will discuss colonialism in global health. And I would also just like to give a quick shout out for an interview, an extremely important interview that we will have at 12:30 with Dr. Lok Soo on dismantling Asian American xenophobia, given the rise in anti-Asian American violence throughout this pandemic. And then we have some other research talks and cutting edge workshops for our attendees at the end of the day as well. And yeah, so I would like to take this opportunity now to hand it over to Dr. Richard Mamai, who will moderate our panel. I hope to see everyone throughout the conference. And please refer to us or reach out to us or refer to our website, NUGHI.org, for all Zoom links, agenda, and timings. So thank you, and I hope you enjoyed the event.
Thank you very much, Fatema, and for having me here and our panelists. It's great to be with you and spend this time together here, and also all the attendees, students, and other colleagues who are listening in this morning. So we will start first with the introductions, and so we will let each of our panelists introduce themselves. So take a couple of minutes, tell us about yourself, who you are, where you are, and that would be great, including just to know a bit about your work. I think we can start haphazardly, but I think, why don't we start with Nancy, please?
Hi, everyone. I am Nancy. I am a PhD student at the London School of Economics, and I'm in the Department of Methodology. So my research is around looking at the ways that sexual and gender-based violence interventions are implemented in Zambia from an anti-colonial perspective, to therefore work with the community in order to come up with community-led and community-centered alternatives for sexual violence interventions. And I'm really excited for this discussion.
Thank you very much, Nancy. And how about Dr. Lodat, please? Go ahead.
Thank you. My name is Tamam Al-Wadat. I am a Syrian physician, and I have spent most of my career working in humanitarian medicine for the International Red Cross and Red Crescent movement and Médecins Sans Frontières, Doctors Without Borders, for the past 10 years now. Currently, I work on the MSF Access Campaign, which argues on the availability and affordability of medicines, including challenging monopolies and patents by pharmaceutical companies. Thank you.
Thank you, Dr. Lodat. And how about Dr. Karan? Please also introduce yourself.
Hey, everybody. Thank you so much. My name is Dr. Abar Karan. I am a clinical physician at Brigham and Women's Hospital and a researcher at Harvard Medical School. I guess relevant to this panel, I'd worked on the Massachusetts COVID-19 state response for all of last year. So from February 2020 until about October of 2020, had worked on our state response with the medical commissioner. So can talk a little bit about how that plays into our topic today. and then afterwards had done some consulting for WHO's independent panel on pandemic preparedness and response. And just really happy to be here, just honored to be here with my panelists, and thanks to Fatima and Andrew for setting up this amazing conversation.
Thank you very much, Dr. Karan. And I should say, Nancy is in London, Dr. Lodat is in Geneva, and Dr. Karan is with us close by. So, folks, we are having this event to discuss COVID-19 and racial equity, or racial inequity, perhaps we could say. And our panel today is on distrust on Western medicine rooted in colonialism. So the discussion today has an overview. We talk about COVID-19, we talk about role of practitioners on this theme, epidemic illusions, developing solutions, future response, community-led efforts, and priorities, as well as the role of our generation, including, I think, particularly the younger generation, so students who are listening in, and then we'll have closer remarks, we'll have a Q&A. So we'll spend our 30, 40 minutes going through these questions that have been prepared by the NUGHI conference organizers. And so for overview, in light of the racial health disparities, the communities that have been facing calls for decolonization, we will reflect on this more deeply through this discussion. For our panelists, can you introduce what this movement is about and what led you to speak on these issues?
Shall we just jump in?
That's exactly right. Yes, please go ahead.
Thank you, Professor Omai, and thank you for having us here. At first, I'd like to just start by saying, despite the multiple calls and events and talks and publications about decolonizing health, global health, or however it's coming across, I think one of the issues that we need to recognize that this is still an idea that is in the making, that there isn't a uniform or finished product or a roadmap that we should adhere to or are expected to do or finish yet. I think it has become evident, and more so after COVID-19, that there are inequities in the way that health is being seen and delivered across the world. That is across single populations in a given country, but also in the way that what is called global health is governed and given credence. There is a massive disparity in power. There are people who have power to move and make and choose, and others who have to passively accept the decisions that are made in spite of them. Some of those who have struggled with accepting this have chosen decolonizing as a framework. And we can talk whether that's appropriate or not, but I think it is important to start this conversation by acknowledging that this is a movement that dissents the disparities and asymmetries of power, whereby most of the people who are supposedly beneficiaries of the global health system have no say in it. Thank you.
So yeah, I'd say to echo on that, I completely agree. When I was thinking about, again, I kind of think and reflect a lot about what does coloniality mean to me individually as somebody working in global health. And my first sort of experience in global health was in 2007, but it probably started much before that. As I'm Indian by background. I was born in India. I grew up in Los Angeles, but a lot of my time was spent back as a child going to spend time with most of my family who lives there. And I remember over the years, as I became more involved with global health, the idea came up because I went back to work in India, and my cousins there said, "What is global health? This is actually just day-to-day life for us. This is the life that we deal with every time that we walk outside of our apartment or our house." And the first experience I had was actually working in India with some other students who were American, and I was Indian, but American and Indian. And so I was able to have a perspective on the way that Indian culture was being perceived by white American students who were there with me and very well intentioned. And that was a very interesting divide to really feel, right? There's a feeling that we are a group and there is a different other group. And then where does coloniality play into that, right? So I think about, again, as Dr. Aludaz said, power, and how does power get assigned or taken or stolen? How does it get retained? And what role does the historical perspective have on that? So a lot of my friends would say, wow, this is such great work that you're doing, global health work. This was back in 2008, 2009. Coloniality, at least within the college realm of global health, was not something that we were really thinking and talking about. It was just, wow, we're going and doing these trips or this kind of work in other places, and we're getting patted on our back when some of our other college friends were on spring break trips or partying in the summer. We were doing global health work. But as time went on, it really started to feel like, should we be getting all this credit and why do these inequities exist at all? And are we actually helping other people, or are we giving back things that were stolen from other places? And so I encourage everybody to sort of think on your individual journey in global health, whatever work you're starting to do or are doing, to bring in that historical perspective and try to figure out where you're actually fitting into that.
Thank you. And Nancy?
Thank you. Yeah, just like Dr. Karan said, I mean, people have been doing this work of decoloniality for a very long time. And so now we are formally trying to implement it in global health and development. And I think that what has been said for generations, and especially now, what that takes is taking up less space, dominant voices taking up less space to allow some sort of equilibrium, so that way there is some sort of mutual accountability through all stakeholders. And so where I kind of brought myself to this place was through my work domestically in the US, working with indigenous folks in New Mexico. I was doing work on sexual violence interventions, evaluating programs and policies and other interventions like that. And essentially what it came down to was I was wondering why indigenous communities were not reporting to sexual violence to police institutions, and also gaining services from health service support services. And I ended up being told by the community that I'm asking the wrong questions and that I'm measuring what is success based on Western and white-centered measures, and that we need to be asking more questions about why this is even existing and the root causes of structural manifestations that are happening in such communities, so that way we can look at it from a very intersectional perspective. And so, I mean, that requires me to be very reflexive about, okay, well, I'm coming in with this certain perspective through my own training, through this formalized training that is very Western centered. And so we need to give more power, not even just giving more power, but just allow space so that way communities can take up their own power and create some sort of collective agency, so that way we can make some sort of transformative change.
Yeah, thank you very much. As a personal journey for me too, growing up in Kenya, my father fought in was a clinician in the Second World War. My mother spent 3 years in prison in the British camps. And then my father practiced public health in our villages. So I can see the perspective of our topic mirroring and captured in my own family experience and my own career over the years now as a professor. I wonder whether, and not to, just as we continue in this discussion, to reflect whether in fact we have a movement for decolonizing global health, whether we can actually call it a movement yet. These conversations are happening. I have heard the American Society for Tropical Med and Hygiene Conference had a discussion on decolonizing global health last year. We just last weekend had a conference of the Consortium of Universities for Global Health, and there was a panel on the same subject as well. So it's appropriate that we are having this discussion even in this setting as well. So to move on to our topic on COVID, particularly, perhaps more closely, what examples of how the legacy of colonialism is manifested by past initiatives by non-government organizations and the world's COVID-19 response? Perhaps any specific examples you could highlight in this context, and anyone can then jump in the discussion.
I think there's almost too many to highlight. You know, from the very beginning. If you think back to early 2020, when we realized that COVID was going to be a pandemic, a lot of the sort of assumptions were that the UK and Europe and the United States, or so-called high-income places, were going to be having the best responses. That they had the sort of knowledge, the expertise, the resources, et cetera, to have a good response to the epidemic, right? Or among the best. And we saw exactly the opposite happen. And we saw that actually our colleagues in Asian countries who had dealt with SARS, our colleagues in sub-Saharan African countries that had dealt with Ebola and other epidemics, that they actually had the knowledge, the experience, the institutional memory of how you deal with epidemics. The people in those countries had already suffered through epidemics, right? And so you had local expertise, community expertise, neighborhood expertise. In the United States, we were caught completely off guard. Nobody knew what to do, how to respond. Even on a state level, on a federal level, it was all over the place. And we saw that in the outcomes that were then generated from that system. But I want to bring it back to the assumption that high-income countries somehow are better at everything, right? And that low or middle-income countries are somehow there to be recipients of our expertise or our knowledge. Actually, I think, if anything, the knowledge is all spread into many other places. It's actually much of the resources that are hoarded or stolen or sort of held over by high-income countries. And we're seeing that now with vaccines. We saw that with access to medications like remdesivir. We saw that with access to ventilators and other critical care supplies. And those were systems that had already existed pre-COVID. I mean, this was like a slingshot that was pulled, just waiting to be released, because those inequities were already, that was the landscape beforehand. And anybody that was surprised by the outcomes that we had, even within the United States, was not paying attention to the inequities that were already brewing. It's no surprise that the communities that were hit hardest here were hit. The only surprise is that people acted surprised about it.
Thank you, Dr. Karan.
Thank you. That's a very good point. I mean, it'd be a little simplistic to say that this is coloniality is as opposed to colonialism, because many people argue when we talk about decolonizing global health, colonialism is done, stop using far-fetched metaphors. And here it is not a metaphor for colonialism as much as examining two aspects. Countries that are in power today are largely in power because of their exploitation through hundreds of years of colonial history. And they continue to practice power that was imparted on them by their history of colonialism. So the United States, Western Europe are not rich by accident, and they aren't rich because, as many like to say, because the creativity and civilization was invented there. Hence, they are ahead of the rest. They are rich now because they have made a world over hundreds of years where it is them that have gotten the outcomes of it. So you look at countries that are suffering from very ill health, and all of them, almost all of them, have been plundered by European colonialism. Haiti, which has suffered and continues to suffer, has in nearly 1800.
Sorry, Dr. Laudat, I think we lost your connection for a moment. Nancy, would you respond and share your remarks, and then we'll we'll have Dr. Lodat join in. Hopefully the connection will just resume in a minute.
Sure. I think that COVID provides, the pandemic provides an opportunity for us to see the ways that different communities are over-experiencing and being over-impacted by COVID. And it's not based on biology, as oftentimes diseases are pointed towards. Communities are basically said, okay, well, these communities, especially people, communities of color, are experiencing certain diseases and epidemics because of their race. And I think that COVID is providing an opportunity to see that it's structural inequities that are creating opportunities for these communities to be hit in disproportionate ways when we think about housing, access to health, just community mobilization in general. And so I think that if we want to move past this and create some sort of structural change, then we need to look at those individual or intersecting realities that exist in these communities and address them.
Mm-hmm. Yeah, thank you very much. It would be fantastic to hear the conclusion of the point that Dr. Lodat was mentioning, and I see the direction that he was going with his comment regarding how these power imbalances came about, how wealth became distributed, global wealth became distributed so that it's concentrated in the former colonial centers, and the global south still maintains large bodies of knowledge, like Dr. C.A.R.E was saying, and experiences in coping and dealing with pandemics such as COVID-19. Let's move on to the next area of our discussion. I'm sure these issues will interact as we go ahead. The role of practitioners. So Dr. C.A.R.E, previously you have spoken at NPR. These are some of the comments you made there, that at its worst, global health today is a self-congratulatory neocolonial machine in which doctors, professors, researchers, and others from wealthy places with abounding privilege are further exalted because they are doing work that their global south counterparts do as part of their everyday lives with little to no recognition. And at its best, you said it is a humble attempt to equal the playing field of life between North and South by trying to unravel the tightly bound chains of colonialism. So Dr. C.A.R.E, I will hold the question because you had touched on it early on in your initial remark. And for our attendees, how should we reimagine global health to avoid perpetuating these kind of problems that you spoke about at NPR? But let's hold that thought because we have Dr. Lodat, and Dr. Lodat, we are really curious to hear the conclusion of your line of thought there. So welcome.
I am very sorry that my internet had to die, but what I was saying is, to cut it short, colonialism is a determinant of where we are now, but it continues to be practiced as a force that continues the status quo. And I'll give a small example. Today, the vaccines, the intellectual property of the vaccines of COVID-19 is being protected by international law, by the World Trade Organization law. Countries like India and South Africa proposed a waiver. So should we not allow pharmaceutical companies to gain billions and billions of dollars through intellectual property that they gained by public funding? As you know, $20 billion were put between Europe and North America into the research of COVID-19. And the resistance isn't coming only from the pharmaceutical companies. The resistance is coming from the United States, Canada, European Union, Britain, Norway, Scandinavian countries who do not want their companies to lose the intellectual property they have, even if that is at the expense of poorer countries not being able to cover their citizens, even those at highest risk, for a very long time. So that is where we are. And the last thing I'd say is it's hard to think of colonialism or the legacy of colonialism without thinking at the other regimes of domination of our time. And this is a neoliberal, fanatical, market-based conception of the world. and a national populist sentiment that is increasing as we're seeing the results of elections upon elections in democratic countries. Those forces are exclusionary, discriminatory, and care about their own success. So we cannot anymore with ease and clarity think about global health as just a benevolent system that aims to make everybody healthy. We have to be a bit more critical about it.
Thank you very much. I think that ends well the point to continue in our discussion. So Dr. Karan, the question was in context of what you were speaking at NPR, scathing criticism of the global health infrastructure and its practice today. So how should we reimagine global health to avoid perpetuating then these problems? Could you just speak to that, please?
Sure. I mean, so when I wrote this piece, like if you examine the piece and the author, it was written from a author who I'm a clinician in an academic medical center in the United States by background, by family, etc. I'm both American and Indian. And so this essay that I had written really came from an introspection about what role was I playing and what other people in our field within the United States academic global health enterprise playing in this. And so it's actually similar to what Eugene Richardson, who was originally going to be on this panel, had said. I actually have a quote here from him from in his book, and he says, "However, as an apparatus of coloniality, public health manages as a profession and maintains as an academic enterprise global health inequity." And you really think about what that means. If in fact the goal is to completely remove inequity, then global health may not need to exist as it purports that it needs to exist. And so if in fact the real goal is to stop that inequity, there are many things that we can do, right? We talk about reparations, we talk about moving power. But remember, when you move power, you remove it from somebody or some group and you give it to some other entity. And if we don't acknowledge that transference of power is an equalization of the playing field, then in fact, we're missing a big portion of why there is not as much radical change as there is smaller incremental change. And as we saw with COVID, actually incrementalism is to the detriment and death of many people who are Black and brown in the United States and around the world. And so if we're hesitant to make drastic changes that can be made, for instance, as Dr. Aludad said, liberalization of intellectual patent rights around vaccines and actually mobilization of how to, of the materials and supports that are needed to get vaccines to places that don't have them, that could be done immediately, right? That could be done within days to weeks. Why is it not? And who is dying in the process gets back to exactly the same point. Where is power? How is power being protected for whom? And what does that mean for everybody else? And so you asked specifically, what might we do at an individual level? Well, transference of resources, of materials, of power in ways that people can actually operationalize that for better health outcomes is key. How do you do that? I'll give you one example. So people had pushed back a lot when the Black Lives Matter protests were happening here in Boston. And myself and other doctors said, yes, they're happening. Yes, they may, in fact, the crowding may lead to more cases of COVID, but what is being argued for here is actually the fundamental reason that we are seeing the inequities in COVID to begin with, right? The deep-rooted racism is not that has everything to do with why Black and brown communities are being disproportionately hit by COVID. And after those protests, we got testing centers in parts of Boston that did not have it before immediately, within days, right? And for months, we were told by state and other officials that, oh, we can't get testing over there. They got testing over there because there was a concern that there could be more spread of COVID and this would get out to other places. And those material resources were immediately moved. And they were immediately moved when there was a threat to power, when there was a threat to the health of other people in the rest of the city or in the rest of the state, because they didn't want large outbreaks. And then there were resources given. And so this actually, and I'll end it here, but it gets at the notion of global health security. What does global health security, or what does even local security mean? Does it in fact mean protecting the health of the wealthy and because of the need to do that, protecting the health of the impoverished. So I'll leave it there.
Mm. Thank you very much. Yeah, I think that's a very well-rounded response. I wonder whether Dr. Lodat has a comment to that, or Nancy, you have anything to add there? We have a question coming for Dr. Lodat going forward, but any sort of remark that you want to add to what Dr. Kran has said here? Okay.
If question, I'll leave it to Nancy if she wants to say something for now.
Okay, great. So let's then totally agree. I mean, that point about incrementalism, Dr. Krani said, obviously, what you're advocating for is a radical and immediate shift with what can be done. Clearly, yeah, because incrementalism means delaying what ought to be done, and therefore leads to increasing deaths of people in many places. So for solutions, when we hear conversations on decolonizing global health, this is a question to Dr. Lodat, we often hear about diversifying leadership, listening to communities, and so on and so on. But in a recent interview, you say, Dr. Lodat, you mentioned how these promises are not enough, that we need to acknowledge our past failures, develop context-specific solutions, and give power to these communities. So what should institutions be doing to address these problems?
Yes, thank you again. I think it's, look, diversity and inclusion as they are advocated and proposed today are necessary. We cannot continue to have a global health system that is governed, managed, presented by a very narrow strata of, you know, Western white, usually men in middle age who have the entitlement and the ability and the connections to continue full domination on the system. We cannot accept for much longer that people who sit in Washington, D.C., New York, Geneva, London, Paris, and similar are making daily decisions that will get people in Africa, Asia, Middle East to die or live according to the resources that are allocated. So a first step, diversity, yes, of course. The problem with diversity is we end up getting hired people of color who are assimilated and find it nearly impossible to oppose the existing power. So having more diversity is not a guarantee of a change that is proportional. It will take much longer than it needs to. Now, other solutions. Well, other solutions is to start to disrupt the system. The other solutions is to start to not accept. So if we talk about the COVID issue, the countries, ex-colonial countries have been threatening in WTO negotiations, poorer countries that wanted to vote for the waiver on intellectual property. There is still a near complete domination. So that narrative has to change. We have to stop wanting to exclusively change the system through incremental, nice, polite steps whereby we sit on panels and meetings and we try to convince people that it's not appropriate for people who live and die of the diseases we talk about to have nearly no say in them. I will refer back to an editorial letter that was written in The Lancet by Lioba Hirsch of London School of Hygiene and Tropical Medicine. She quotes Fanon. Frantz Fanon was a Martinican anti-colonial figure from the 50s, and he's written very forcefully. And this is where talking about decolonizing is useful, because we have behind us 100 years of thought and practice. And Fanon changed during his life as he experienced the violence of colonialism more and more, from being very timid to being much more forceful. And obviously, we're not definitely by any means advocating for a violent response to the coloniality of global health, but we are saying that there has to be solutions that have to be explored and accepted as possible solutions that do not go through the system as it's done now. And the last, I will just quote, Audre Lorde said one thing that has to hang in everybody's mind. You can't use the master's tools to dismantle the master's house. We have to find our voice, we have to find our tools, and we have to go forward.
Thank you very much. Well said with that. I wonder if there's any addition to that, to add that voice, Dr. Kran, Nancy? Okay, so here's the thing, Dr. Lodat. One thing that I heard recently was in Australia. So Australia launched a commission, the first commission after 200 years, to examine the colonial impact on the Aboriginal population in Australia. Perhaps, as far as perhaps solutions go, maybe that is a good step in the right direction for a country like Australia there. Let's look a little bit about future responses. So on a global scale, how can we generate more dialogue and design policies designed in a culturally sensitive and equitable manner? Perhaps think of implications for the so-called aid sector. We had a speaker yesterday, Dr. Mark Dubel, who said the term that we use, even calling it aid, is just paternalistic, and the terminologies itself also matters here. What's the implication of a future response to the current global structure where global health is, on one level, is transferring resources held in the north to the global south to improve health in those areas? So how can we generate more dialogue, perhaps to redesign this system?
Well, one thing I would say is just looking at it locally here in Boston. One thing that became apparent when I was working on state level policies were that a lot of policies are written for communities rather than by communities. And when you don't have community input into what they need to happen, you're making a lot of assumptions that are filled with biases, and those biases are probably to retain things and not change them or shake them up too much. And so you move away from any sort of a radical change and you move right back to incremental change or no change at all. And so when we talk about in the global health setting, the same thing, what are the policies that are written? Well, who are the people at the table that are getting to write those policies, and what level of power do they have to do so? And so I would examine that, and I'd examine how we change who gets a seat at that table, and how those policies are implemented and enforced, and what accountability there is to that enforcement, right? Because there's a lot of words can be written on paper, but if there's no teeth behind those, and that they end up being just words on paper, and words on paper alone is not what saves people's lives.
Yeah, thank you. Nancy, any thought?
Yeah, so I'm currently conducting a discursive analysis on policies implemented to address women's empowerment in international aid and development, like CEDAW, the Convention of the Elimination of Discrimination Against Women, and other local policies that were created through the influence of CEDAW. And one of the biggest discourses that I critique is around protecting women in marginalized and vulnerable communities, limited discourses or even no discourse around empowering communities. And so this discourse of protection that we in the global north have kind of implemented, it generates a savior complex that removes agency from communities. And it reveals that there's still some doubts that we in the global north have on the capacity for community to take on their own collective agency. So we need to be mindful of those discourses that we engage in, and that they end up permeating those interventions and approaches that we take. So engaging with and investing in grassroots activists and practitioners who are in the field or on the ground, and including them in creating policies that are not just about protecting and saving, but also empowering and enabling agencies is what we need to do.
Yeah. Okay, thank you very much. I think we can, Dr. Lodat, as you give your remarks, let's address this last point, which is the role of the young generation, that is the students that we have. For instance, students that I teach, students that we all engage with, and Nancy. So what role does this generation have, and how do we take steps to put decolonization in practice? What can the young people do? These students we are teaching global health today.
First, let me, in the past couple of years, I've had the privilege of interacting with many medical students, postgrad students, and so on. So, in their early 20s, they have more substance and consciousness than I have even knew existed at that stage in my life. And that is encouraging. That is a good thing. We are having people who want to listen to this and want to talk about it, want to act, and acknowledging that the decolonizing movement has started by students in universities. So the first thing to acknowledge is maybe we should learn from them rather than try to tell them what to do, because we are catching on this train way after student movements have started. So that being the case, I think in my humble view, we talk here in the title about distrust in medicine. And the distrust here needs to be dissected a little bit. I don't think many of us distrust in evidence-based biomedical, we don't distrust what microscopes and pathology labs and chemistry labs tell us. We distrust in the moment this becomes what is described illness or sickness. How does that proceed by the person who suffers from it, and how is it assigned and understood by the community? Part of it is pretty evident in the United States. There's plenty of literature. The amount of painkillers are given to a Black person are generally less than those given to a white person in an emergency room in the United States, regardless to whether the symptoms, even when the symptoms are the same. There is the distrust in how medicine gets absorbed and held hostage by social and economic and political stigmas and biases. So what can you do? Don't, for medical students to start with, don't bask in the comfort of knowing that you are doing something that's evidence-based and is unchallengeable. It is. The way you apply it makes a difference. The way you see people you help makes a difference. In global health, I honestly don't see a way where institutions that are benefiting from the power are going to, out of the goodness of their hearts, change themselves so they lose power. So that has to happen through pressure from the bottom, and that is the responsibility of any one of us. Just like the combating colonialism in its time, but also just like the civil liberties movements in the US and elsewhere, it is everybody's duty, and it will happen once enough people own into it and rise up and make it part of their lives. The last thing is, no struggle is suspended in vacuum. All the causes are interlinked, whether you are concerned about the climate crisis, or concerned about the erosion of democracy, or concerned about the health of people beyond your own borders. There's more overlap, and there's more need for us to talk to each other than we often realize. I'll leave it here. Thank you very much.
Yeah, thank you very much. So last observations on this, and we have 1 minute. So Dr. Karan, a short response, and Nancy as well to that question.
Sure, yeah. I mean, I totally agree with Dr. Aladat that, rather than us being prescriptive from an academic lens or whatnot, these movements are ground up, right? They come from communities, they come from people who want to make real change. And so I would say to like any students, if I could look back when I was doing my earlier global health work in 2007, 8, 9, 10, it was all with small NGOs that many people had probably not heard of in community settings, trying to get things done for people, with people, and seeing what I could leverage as an American college student. What kind of resources, what kind of things could I do to work within local communities? And that does not have to be overseas. That could be and should be right here in Boston too. There's so much to be done. There's a lot of things we can talk about, but there's even more things that we should be actually doing. And I think students are the best at this. They really are closest to the ground.
Thank you. And Nancy? very briefly.
Yeah, I'm also very inspired by the youth, and I think that there's an opportunity for global public health to be transformed moving forward. Namely, I mean, within global public health, we pride ourselves to be intersectional and take social behavior and norms into account in the interventions that we put forward. But then we often ignore the stories and narratives of the marginalized that contextualize epidemic phenomena, because that is seemingly more legitimate. And I think the way forward is to stay true to that intersectionality and apply decolonial and anti-colonial theory and stories of resistance in our practice, because it's around, it's been around for ages in radical spaces. So if we're looking to make transformative change, we have to find ways to engage with radical community leaders, not just those who fit within the status quo.
Thank you very much. Okay, so we're going to end here, and I'm going to share an article that was just published within the last few weeks, and it identifies 5 approaches to decolonizing global health. One of those has to do with curricular development. I'm encouraged to hear this University of Global Health Equity in Rwanda medical school, medical students, first 6 months, they study African history. And I would encourage the same thing in terms of just understanding these historical dynamics of where medicine is at, where it came from, what are the populations and societies that we are working with. So I encourage all students to read and review that article, which I'll include in my curricula going forward. So thank you all very much to our panelists. I think we have a Q&A section for the next 10, perhaps 10, 15 minutes. So I'll leave Fatima, please come on, and you have been observing the chart. There are a few questions that we can discuss. So please go ahead, Fatima.
Yeah, absolutely. Thank you so much, Dr. Ramai and Nancy, Dr. Lulith, and Dr. Karan for that really insightful discussion. So I think we have time for 1 or 2 questions. This is from Katie in the chat. She said, "Thank you for an amazing panel. So the US has much to learn from countries in the global South about community health, health justice, and what well-being and caretaking truly look like. Can you reflect on the colonial dynamics at play here, whether we're thinking about which voices are highlighted as experts, or more materially in terms of free migration flows in academic systems, and this imbalance between how we think of ourselves as having the white man's burden of bringing health and development to global South countries, even as we are so blatantly failing to build our own effective and just health or social systems?"
Oh, that's a question. God, look, I'll give you a small example that was published recently in the Guardian, but that I've talked to with a friend and a colleague who is a Maori, an Aboriginal person. And New Zealand is being praised for having controlled COVID-19 very effectively, and New Zealand continues to be, just like Australia, United States, and Canada, a settler colonialist country. So this is one thing. If we are going to examine history, let's examine history. Those countries have still not solved the fact that they have occupied land and destituted Aboriginal communities or native communities. So the Maoris in New Zealand have taken over the control of COVID in their own tribes and communities. And they have managed to stop the transmission before the government could do it anywhere else. And with a full understanding and full autonomy to know how should it be done. So this is a great example, because it is an example of where the experts are the local people. The difficulty is not in the biomedical knowledge alone. The difficulty is in applying that in a societal context where it works and it doesn't harm and it doesn't have negative external. There isn't any population that I've worked in enough places to know that there isn't a population who are completely passive, who completely who are unable to make any decision about their lives. We treat them as such, and that needs to stop. So how do we perceive ourselves? I think global health falls into, thank you for bringing the white man's burden. This comes from a poem by Kipling, who sent it to the US president at the time, encouraging him to invade the Philippines. So this is like and he's claiming that the white men have a burden, a duty to civilize and save the poor, childlike, savage peoples. And don't think that this is history. The current Prime Minister of the UK was recited Kipling in Visit to Myanmar, and the savage, colonialist history in Myanmar by the British Empire is still a problem. So empires and colonialism isn't universally seen as a bad thing yet, but we need to examine whether, as mostly Western or Western-based global health system, we have a parallel healing mission, whereby we think it's our job to heal people despite what they want. And that is a first examination. Again, I think it needs to happen by each one of us challenging what we know or what we think we know. And in that sense, anthropology and sociology and philosophy are your allies. And if I was just to compliment Dr. Wambai's the recommendation of reading, anyone who has some time at their hand, there's a book by Thomas Piketty called Capital and Ideology, and it lays out the history of colonialism and the economics that preceded and followed it. It's not about colonialism, it's an economic history, but it's one of the most eye-opening books. It is 1,000 pages, I'm sorry about that, but if you have a desire or the time to read a chapter or two, it is one of the best things you would, that would help conceptualize some of those issues. Thank you very much.
Thank you, Dr. Lulith. I think we can move to the next question. This is directed towards Nancy, and given your background in community-led efforts to decolonize global health, can you share a bit more about your experience on the ground?
Sure, it's a very general question, but I will try to respond. I mean, so right now, doing my community work, or the community work, has really shifted because of COVID. Like I said, my work is in Zambia, and I'm not in Zambia, but so what has happened instead is that it's allowed me to take up less space. And so the research team who I'm working with, who are in the field right now, are the ones who are doing a lot of the work that I intended to do alongside, but I'm kind of hearing their reflections more so. So it's allowing me to be more reflexive about how much power I have over what is being done with the research. And that means that the community is taking up more power and more agency around the work. That requires, I'm seeing this other question about what we need to consider so we're not complicit in the problem. So maybe I can kind of make this connection of just being reflexive about what knowledge we have and what our position is in the work that we do, and being ready to be checked and being accountable as we're doing this work. If we're coming with our own perceived notions about what should be done and the community is saying to us, no, actually this doesn't work, or actually we've been doing this and this works really well, or actually we're really interested in this, or this problem is more important than what you're proposing, then holding space for that is really necessary, because otherwise what's the point of doing community work? What's the point of decolonizing anything if you're not willing to take up less power and less space? I hope that answers the question.
Thank you, Nancy. Dr. Kern, did you have anything?
Yeah, just one point I would add. If there's two ways two things I'd want to leave here. One would be decolonizing how we think, and the second is decolonizing in what we actually do, right? And so, actually, the title of the whole topic here, Distrust of Western Medicine Rooted in Colonialism. Distrust has been brought up right now with vaccines a lot in the US, and it's been placed as Black and brown communities have a distrust of the medical system, and so their vaccine uptake is lower. And some people have weaponized this to say that that's we need everyone to get vaccinated, so people that are not getting vaccinated are harming that cause. And actually, a colleague of mine wrote a great piece in New York Times, which basically said that it's not vaccine attitudes, it's vaccine access that's a problem. A lot of the Black and brown community don't have access to the vaccine. The resources are not there. And yet this legacy, this historical sort of mistrust of the medical system is now being weaponized against Black and brown communities to say that they're distrustful, when actually what they need is access. And so I'd say it's important to decolonize how we think, meaning we need to place interventions of health, such as vaccines, within the historical context of how Black and brown communities and bodies have been exploited and harmed and killed. But with that, we also need to decolonize in what we do, which means that we need to get things to people. We need to get resources to people. And so I would make sure that as you think about this, don't let the two things become confounded, as they often can be, and often can be used to do nothing. That in itself is a big problem as well.
All right, thank you very much, Dr. Karan, Dr. Alodat, and Nancy. I think, Fatima, are we close to the end of our time? Okay. Yeah, great. So let me thank our panelists for this 1 hour that we spent together and the perspective that you bring to the conversation. I'm sure this is not the end of the conversation. The conversation continues in all our work. And what I think encourages me is just the fact that students, like the students we have here and our colleagues, are taking part in this discussion. And I think this is a conversation that will continue to go on, and you young students, you're the ones building your career in the future. So what this conversation helps us to do is to build and bring these perspectives in your education so that you can become those future leaders. Clearly, this asymmetry of global health will not change without a change in leadership at some point. And I think the path towards that is to begin learning these histories and then deconstructing the histories using the resources that we have, such as those we've shared here, and going forward. So thank you, Dr. Karan, Dr. Alodat, again, Nancy, all the best, and back to Fatima to close out on our panel. But thanks to everybody and all our listeners to this discussion.
Thank you, Dr. Omai, for moderating this panel. I know everyone, including myself, really enjoyed the discussion, and thank you to all our panelists for being here. We will stay in touch, and we hope to host future events with you. I will now pass it on to my colleague, Ramya, who will introduce our next event. Thank you.
Hi, everyone. Thank you again to the incredible panelists. That was a really wonderful discussion. We're now going to